My final project for application of genetics to healthcare. Did it on the factor V Leiden thrombophilia. Okay, so what is factor V Leiden thrombophilia? Well, what is thrombophilia in the first place? Thrombophilia is basically a hypercoagulable or prothrombotic state, usually causing increased blood clots, etc. It is the most common form of thrombophilia. 40 to 50% of all cases of thrombophilia are factor V Leiden. A couple different types of it. I'll get into the details of that later, but you can either be heterozygous or homozygous. Heterozygous factor V occurs in 3 to 8% of the general US and European populations. Highest in Europe. And it pretty low and rare in Asian, African, and indigenous Australian populations from the data that we have. You can kind of peek at that little chart I have over there on the right side. Discovered relatively recently, 1994. The history of it is kind of unknown. It suggests that the data suggests that there was a mutation, a single event that occurred 20 to 30,000 years ago, after the evolutionary separation of whites from Asians and Africans. The high prevalence kind of suggests that there's like a survival advantage that came with it. So what is believed is that the hypercoagulable state could have decreased death related to birth or trauma before modern medicine, before medicine became what it is today. Just a side note here, Leiden is not the name of anybody or a specific person. It is actually the city where the Dutch first identified this mutation. Okay, so clinical expression and manifestations of factor V Leiden thrombophilia, it's variable. The primary clinical manifestation is VTE. It's found in 25% of patients that have an idiopathic first VTE and up to 40 to 50 actually of those with recurrent VTE. Now, before I go into further detail, it's important for me to discuss the two different types. I know we're not into the mechanism yet, but basically you can either be homozygous or heterozygous for the gene malfunction, and that plays a large role in how you present. This variability in presentation depends a lot on whether you get 1 or 2 copies of the gene. Homozygotes are more likely to develop VTE at a younger age. About 40% had one before 33 years old, per the data, and as little as 10% of heterozygotes develop a VTE in their entire lifetime. So there's a pretty significant difference there. Exponentially higher chance of developing a VTE as a homozygote rather than a heterozygote. Obviously, PE is a risk factor for developing a thrombus and VTE. And on top of it, factor V Leiden is also associated with a 2 to 3-fold increased risk for pregnancy loss, in addition to environmental factors and everything like that. A large number of case studies have found a high prevalence of factor V Leiden heterozygosity in women with unexplained recurrent pregnancy loss, which was actually up to 30%, which to me is pretty shocking. This factor V Leiden, it suggests that you're at a higher risk for late pregnancy loss more than early first trimester loss. And they think that this is because late pregnancy losses reflect thrombosis of the placental vessels in contrast to first trimester losses, which are more attributable to other causes. There's a loose connection with other obstetric complications. It's unlikely that a single thrombophilic defect plays a major causal role in everything, but I will mention that there is connecting data on intrauterine growth restriction and placental abruption. So it was retrospective and the study was underpowered, but it is mentioned in some of the expression and complications due to factor V Leiden. Indications for testing for factor V Leiden thrombophilia, pretty much based on the likelihood that it's going to change the current treatment regimen. There's no evidence that shows testing will decrease recurrent VTE risk or clinical manifestation or event that will happen in the future. It's appropriate in certain individuals. I have a list here, kind of boring, but first, unprovoked VTE at any age, especially if they're less than 50. A history of recurrent VTE, venous thrombosis at unusual sites like cerebral, mesenteric, hepatic, or portal veins, VTE during pregnancy, VTE associated with the use of estrogen, contraception, or hormone replacement therapy, or a first VTE with a first-degree family member with VTE before the age of 50. So as you can see, it kind of is familial based on other risk factors. There's no specific guideline. It's just all these kind of recommendations for if you have risk factors, if you get VTE at an early age. The way that we test for factor V Leiden is either through an APC resistance assay, a coagulation screen test, or a DNA analysis of the F5 gene, which you'll hear about more in my next slide about the mechanics. So how does factor V work? What is the mechanism behind it? Well, it's first important to remember what our clotting cascade looks like, where factor V is involved. It's right before the final common pathway, in the brackets at the bottom there. 5A in conjunction with 10A helps convert prothrombin into thrombin. So that's like pretty low down. That's right before you do create that fibrin clot. Now, poor anticoagulation response from APC is what causes this clotting disorder. What is APC? APC is a natural anticoagulant protein that cleaves and inactivates both factor Va and AA, which downregulates thrombin generation. So basically it inactivates this 5A protein that's floating around in your blood and causes it to go back to factor V, not 5A, right? So you're not in that hypercoagulable state. It cleaves factor Va by cleaving it at 3 different specific amino acid positions on arginine 306, arginine 506, and arginine 679. Now those 3 points are important to remember as it plays a large role, as I will discuss on the next slide. So continuing on further with the mechanism, basically factor V Leiden is specifically a substitution of guanine to adenine at nucleotide 1691 in the factor V gene. It's a SNP. It's a single nucleotide polymorphism. This genetic code codes for a substitute of glutamine at arginine at the specific arginine 506 cleave site. Now, if you remember, there are 3 sites for which APC cleaves factor V: 306, 506, and 679. So this is one of the specific cleaving sites that APC cannot recognize to cleave factor V. That is the exact specific mechanism for which this SNP works. It is autosomal dominant inheritance with incomplete penetration. As we know, there's a large difference between homozygous and heterozygous carriers. Talked about their risks between the two groups. I threw a couple charts down here for you to look at again. There are two kind of little different phenotypes that I didn't really talk about. The first one is pseudohomozygous. Now, pseudohomozygous is someone that is heterozygous for factor V Leiden thrombophilia, but they also have shown some sort of APC resistance from either another disorder or something like that. So they are not actually homozygous. They are heterozygous, but they act homozygous, as in they are at a higher risk of clotting, or their recurrent DVTs are worse, potentially indicating another form of treatment. And then the last thing I haven't discussed is that in rare cases, both a null allele and the factor V Leiden mutation can occur on the same chromosome in a cis configuration, which, as I said, very rare. The resulting quantitative deficiency here prevents expression of the factor V Leiden mutation, and they are normal, basically. The management and treatment of factor V Leiden thrombophilia is very patient. It's case dependent. Factor V pretty much often coexists with other inherited or acquired disorders. Should be tested for these once you do have your first thrombotic event, especially if unprovoked, which we have gone over. So if you do have these other risks for thrombophilic events and thrombosis, your treatment is going to be different than someone who never finds out that they're a heterozygous factor V Leiden. So basically you want to evaluate for these other genetic risk factors and disorders. However, initially you're going to treat whatever acute manifestation has occurred. So if it's a DVT, you're going to use your low molecular weight heparin, you're going to be using your IV unfractionated heparin, whatever, warfarin for your stroke, your PE, whatever event has occurred, you treat it by your standard guidelines. The optimal duration of anticoagulation for factor V Leiden heterozygotes, it's debated a lot. It's generally not an indication for anticoagulation long term, especially if there are no other risk factors involved. Long-term anticoagulation is recommended for a few different populations, especially for individuals with recurrent unprovoked VTE and no other bleeding risk factors. A lot of this is like risk versus benefit analysis, and we're going to be looking at risks of bleeding versus risks of clotting. Is it worth it to anticoagulate you for a long time? Homozygous factor V Leiden or patients with multiple thrombophilic disorders. Now this is for sure an indication for long-term anticoagulation. These individuals are at high risk for reoccurrence. And again, as long as the benefit outweighs the risk of bleeding events, then we will definitely long-term anticoagulate these people. Now during pregnancy, it's a little bit different. As I talked about, there are some pregnancy complications associated with factor V Leiden. Women that are going to be pregnant or currently are pregnant, especially if they have factor V, should be warned about the potential thrombotic complications. They should be counseled about the risks, but there's really no data, no studies that are done about treating pregnant women with low molecular weight heparin and preventing like a pregnancy loss. Now, they do say there should be a course of anticoagulation, 4 to 6 weeks postpartum after delivery. That is where you're at the greatest thrombotic risk, and it has shown to prove, I guess, helpful. So as for ethical, financial, social considerations, there is a pretty high prevalence of factor V Leiden in the general population. It's important that we educate those that test positive about the repercussions for life. We want them to know about. We want to educate them about pregnancy, what the risks of having a heterozygote or a homozygote as a child, what the implications mean, what the risks of having an event through their life, whether it be a DVT or a PE. Financially, we can talk about long-term anticoagulation as a finance burden. Not that it's that expensive, but it's something to think about. We can also think of the social considerations, whether or not you'll be able to eat certain foods or do certain things while on this medication. If you're heterozygote and you're stagnant, you're gonna fly for a 7-hour flight. Maybe you do take some warfarin or some low molecular weight heparin. Just things to think about. And is it something that you're comfortable doing in front of people or on the airplane or whatnot?